Our topic today is about anemia, and actually it will be a case presentation. Our ILOs are to list the common causes of microcytic anemia, to identify cases of anemia who need further investigations, and to construct a plan of management for some cases of anemia, and to know when to refer cases who need further hematological experience. Our case today is a 14-month-old female who presented to the emergency department after an incidental finding of anemia on routine hemoglobin testing at primary care physician, and she was otherwise well. So the parents did not have any complaint. The patient was doing well, was completely normal, and her pallor was discovered incidentally by her primary care physician on routine checkup or routine visits to the primary care physician. Otherwise, the patient was active. Her parents noted no visible blood losses in the stools, urine, or elsewhere, and her parents endorsed a variety of diet with only 2 cups of milk per day. And actually, this is very important. Taking a good dietary history is important in any case of anemia. And I want to stress on the point of the amount of milk per day. So infants and young children should be, of course, beyond the first year of life, should receive only maximum 700 ml per milk per day. From 500 to 700 will be okay. Our children who receive more than that, a large amount of milk, may have a risk factor to develop iron deficiency anemia. Note that milk is a poor source of iron. Moreover, milk decreases the absorption of iron that could be provided from other dietary sources, especially non-heme sources. So this is her CBC that was done in the emergency department. As you can see here, the white blood cell is within normal. The hemoglobin was 3.8. The mean cell volume is 65.4. Her platelets are okay, and the reticulocytic count or percentage was 6.6%. So as you can see from her CBC, the findings is or the findings are that of microcytic anemia. Why microcytic? Because we have a low mean cell volume, and we cannot say a hypochromic anemia because we don't have a mean cell hemoglobin. So we have only the mean cell volume, so we say microcytic anemia. The reticulocytic count is 6.6%. This could seem to be high, but actually this is a low count regarding her hemoglobin, because if the patient is having a good marrow response, we should suppose that the reticulocytic count should be higher. And this actually occurs if there is in cases of hemolysis, or in cases especially patients who have conditions that will stimulate the bone marrow to be hyperactive, like chronic hemolysis. This could stimulate the reticulocytic count. So in short, we're having here a microcytic anemia with a normal reticulocytic count. If we do the corrected reticulocytic count, it will be less than 2%. Okay, so of course our study was done, and this shows, as we see here, a high total iron binding capacity and a low transferrin saturation. The ferritin level was within normal. Her blood type was O positive. Her direct and indirect wounds were negative. Liver enzymes were normal, and total bilirubin was 1.3 milligram per deciliter. So we can see from these findings that the most important things are that total iron binding capacity high, transferrin saturation low with normal serum ferritin. So, based on these laboratory data, what is the likely cause of her anemia? Could it be iron deficiency anemia, or anemia of chronic disease, or a beta thalassemia trait, or maybe a combination of anemia of chronic disease with beta thalassemia, or a combination of anemia of chronic disease and iron deficiency anemia? So what would you think the diagnosis or the most likely diagnosis to be? Actually, the answer is a combination of anemia of chronic disease and iron deficiency anemia. So why did we think of that? Actually, we have overlapping features or overlapping laboratory findings of anemia of chronic disease and iron deficiency anemia. In both conditions, you can find low serum iron and low transferrin saturation. But having the normal ferritin, this would raise the suspicion of anemia of chronic disease. In cases of iron deficiency anemia, the first iron index that will decrease will be the ferritin, because the ferritin is the storage form of iron, and usually this is the first step that occurs in iron deficiency anemia, that the storage will be depleted first, and then there will be no more iron to stimulate or to enhance the erythropoiesis, and at that time the hemoglobin will drop. But the hemoglobin will drop at the late stages of iron deficiency anemia. So we have first a state or a stage of iron deficiency that will be followed by the iron deficiency anemia. And the state of iron deficiency will be mainly manifested in our tests by a low serum ferritin. And when there is no more stores to support the erythropoiesis, then anemia will follow. Ferritin, of course, is known to be an acute phase reactant, and that's why in cases of anemia of chronic disease, you may find it normal or even high. Regarding the mean cell volume, actually the mean cell volume is usually low in cases of iron deficiency anemia. However, in cases of anemia of chronic disease, it could be normal and it could be low. So the low mean cell volume usually supports iron deficiency anemia. But in some cases of anemia of chronic disease, you may find a low MCV also. This table shows the causes of microcytic anemia. The most common causes could be inherited or acquired. Of course, the thalassemia syndromes are the most common inherited disorder that present with microcytic anemia, and iron deficiency anemia is the most common acquired disorder that will lead to microcytic anemia. There are other inherited disorders like the sideroblastic anemia, the iron refractory iron deficiency anemia, and other disorders of iron metabolism as atransferrinemia and divalent metal transporter 1 mutations. And the other acquired disorders that could lead to microcytic anemia include myelodysplastic syndromes with acquired thalassemia, sideroblastic anemias, acquired sideroblastic anemias due to drugs or toxins, including the lead poisoning, copper deficiency, and zinc deficiency. This diagram shows the mechanisms of anemia in cases of chronic illnesses or chronic diseases. That's to say, why do people with anemia of chronic disease manifest anemia, or why do they have anemia? Actually, in the presence of infection, inflammation, or malignancy, there is stimulation of the immune cells, like the macrophages, to produce interleukins or cytokines like interleukin 6 and interleukin 1 beta. And these are very important to stimulate the production of a protein called hepcidin. And hepcidin is actually an iron regulator, or we may say an iron down regulator, because it will stimulate the intestine to decrease iron absorption. It will decrease iron absorption from the intestine. It will stimulate the more production of interleukins from the macrophages, and will decrease iron export from the macrophages. In order to decrease serum iron, it will the hepcidin will decrease iron absorption from the gut and decrease iron export from macrophages, and more interleukins are produced like interleukin 1 beta and tumor necrosis factor alpha. They will act on the kidney to decrease the erythropoietin production and will act directly on the bone marrow to inhibit erythropoiesis. So anemia will occur by direct effect on the bone marrow, reducing erythropoiesis, or indirect through the decreased production of erythropoietin and the production of hepcidin, which is a downregulator of iron, or it decreases iron through decreasing iron absorption from the gut and decreasing iron transport or export from the macrophages. This this figure illustrates the interaction between hepcidin and ferroportin. What is ferroportin? Ferroportin actually is this blue part, which is a protein on the surface of the macrophage, or it is a receptor. It's not a receptor, it is an iron transport channel. And this iron transport channel contains a receptor for hepcidin. As you see here, when hepcidin comes here, it will bind to its receptor on the ferroportin. So the function of this ferroportin is the transport of iron through it, or the export of iron. Actually, when hepcidin binds to its receptor on the ferroportin, what happens is that hepcidin with the ferroportin will be both internalized into the macrophage and they will be dissolved inside the macrophage, and this will prevent iron export out of the cell. This protein or this channel is important because it may be actually affected by two mutations or variety of mutations, but there are two important mutations, one of which will affect the function of the ferroportin. So the function of the ferroportin will be impaired. As you might see here, it will not be functioning and iron export from the cell will not occur. The other mutation is an abnormal hepcidin receptor. Abnormal hepcidin receptor will lead to what? Hepcidin will not be able to bind to its receptor, and therefore it will not prevent iron to be exported from the macrophages or from the cells, and therefore, or from the cells in general. So what will happen is that iron will be exported freely out of the macrophages. This table shows the laboratory findings in different cases of iron deficiency anemia and anemia of chronic disease. So as you can see here, and as I mentioned earlier, that serum iron will be low, of course, in iron deficiency anemia and also in anemia of chronic illness. The transferrin saturation will be low in both conditions because there's no iron to bind to the transferrin, which is a protein binding, an iron binding protein. Of course, serum ferritin, as I mentioned, will be low in iron deficiency anemia long before the anemia appears or start to appear. And in cases of anemia of chronic disease, it will be normal or even high because it's one of the acute phase reactants. And although it's not written here, but if we do a CRP, it may help also because if you find that CRP is high, this could indicate anemia of chronic disease, while in iron deficiency anemia it is expected to be normal. The total iron binding capacity and transferrin are actually the same because the transferrin is the binding protein that is available to bind iron. So in cases of iron deficiency anemia, we are having enough transferrin, but the transferrin will not find iron to bind to it. So the transferrin is high, the total iron binding capacity, or the places that can bind to iron but are not binding to iron because they are free, is called the total iron binding capacity, or the transferrin, and this is high in cases of iron deficiency anemia, while in cases of anemia of chronic disease it will be low, mostly due to low production of the protein transfer. The mean cell volume also might be helpful if we find it low. This is in favor of iron deficiency anemia, but if we find it normal or slightly decreased, this is in favor of anemia of chronic disease. So we go back to our patient. The patient was incidentally found to have anemia. Her CBC showed microcytic anemia with normal reticulocytic count, and her lab findings were the iron study pointed more to the anemia of chronic disease together with anemia of chronic disease and iron deficiency at the same time. So the patient received a packed RBC's transfusion and was started on oral iron, and she improved. Her hemoglobin raised to 8.5 gram per deciliter, and she was discharged in a good condition. Unfortunately, the patient returned after 13 days with a new cough. She developed a new cough. Her oxygen saturation was in the low 90s on room air. Her CBC showed a significant hemoglobin drop to 3.5 gram per deciliter, and her chest X-ray showed the following: diffuse bilateral interstitial infiltrates. So the patient returned with a cough, with low oxygen saturation, with CBC showing a drop in hemoglobin to 3.5 gram per deciliter, and chest X-ray, as you can see, with diffuse bilateral interstitial infiltrates. So, which test most likely will lead to diagnosis? Actually, you might think, what are the possible etiologies, and therefore what is the possible test to diagnose these possibilities. Actually, you have these five choices, whether a CT scan, a bronchoscopy and bronchoalveolar lavage, echocardiogram, oral iron challenge, bone marrow aspirate, and biopsy. So what would you recommend? Yes, the best answer is bronchoscopy and bronchoalveolar lavage. Why? Given the severe anemia, the hypoxemia, and the bilateral interstitial airway disease on the chest X-ray, one might think of diffuse alveolar hemorrhage. The diagnosis of diffuse alveolar hemorrhage can be established by bronchoscopy and bronchoalveolar lavage to identify hemosiderin-laden macrophages, which we call siderophages. So, due to the presence of anemia, the hypoxemia, and the picture in the X-ray, we thought of diffuse alveolar hemorrhage and recommended bronchoscopy and bronchoalveolar lavage. Actually, bronchoalveolar lavage is sensitive to diagnose the presence of pulmonary bleeding, but it's not specific to identify the underlying cause of diffuse alveolar hemorrhage. So it will tell you that there is diffuse alveolar hemorrhage, but what is the cause? You cannot know. The gold standard for diagnosis and identification of the etiology is doing a lung biopsy or obtaining a lung biopsy. However, this is infrequently performed. Infrequently performed because of its invasiveness. So most probably you will proceed with a bronchoalveolar lavage to see if there is hemosiderin-laden macrophages, and then you can do further investigations to know the etiology. The patient underwent actually bronchoscopy and bronchoalveolar lavage, and her fluid was serosanguinous, and the white blood cells was 1,000 per millimeter cube, 64% of which were neutrophils, 6% lymphocytes, 14% monocytes, and 15% mononuclear cells, 1% eosinophils. But astonishingly, or as expected, the RBCs were 76,170 per millimeter cube, and the cytology report showed small numbers of lipid-laden macrophages and moderate numbers of hemosiderin-laden macrophages. So actually, this would support the diagnosis of diffuse alveolar hemorrhage. What is the classic triad of signs and symptoms seen in patients with diffuse alveolar hemorrhage? Is it A, hemoptysis, iron deficiency, anemia, and pulmonary infiltrates, or B, cough, hemoptysis, and hypoxemia, C, dyspnea, pulmonary infiltrates, and fever, D, iron deficiency, anemia, fever, and cough? Actually, any of these symptoms and signs could be present, but what is the classic triad? The answer is A, hemoptysis, iron deficiency, anemia, and pulmonary infiltrates. However, hemoptysis may only be present in 44 to 65% of pediatric patients. So this means that almost half of the patients will not have a symptom of hemoptysis like our patient. And this could be due to the lack of expectoration in young patients who may be more likely to swallow their sputum. The other presenting symptoms would include hypoxia, fevers, wheezing, and microcytic hypochromic anemia in the CBC. Our study typically show a decrease in serum iron, normal or increased serum ferritin, and the normal or decreased total iron binding capacity. So, which of the following tests are part of the evaluation to identify the underlying etiology of diffuse alveolar hemorrhage? Is it urine analysis, echocardiogram, PT, PTT-NIR, anti-nuclear antibody, or all of the above? What is the appropriate answer? Actually, the answer is all of the above. The etiologies of diffuse alveolar hemorrhage are generally separated based on the presence or absence of pulmonary capillaritis. So, cases are classified according to the presence of capillaritis or absence of capillaritis. Pulmonary capillaritis is inflammation and disruption of the alveolar capillary membrane leading to interstitial infiltrate. This diagram shows an algorithm in cases of diffuse alveolar hemorrhage to reach a diagnosis. If you find there is pulmonary capillaritis or the presence of vasculitis will lead to the differential diagnosis of Goodpasture syndrome, systemic lupus erythematosus, or ANCA-associated vasculitis. So, what if there is no pulmonary capillaritis? This is further classified into cardiac causes and non-cardiac causes. The cardiac causes are the causes that will lead to pulmonary congestion like mitral stenosis, like chronic heart failure, or AV malformation. Non-cardiac causes are like bone marrow transplantation, immune deficiency, coagulation disorders, and idiopathic pulmonary hemosiderosis. So, the etiology of diffuse alveolar hemorrhage is classified according to the presence or absence of pulmonary capillaritis. If you have pulmonary capillaritis, so think of Goodpasture syndrome or systemic lupus or ANCA-associated vasculitis. If you don't have pulmonary capillaritis, then you think either of cardiac causes or non-cardiac causes, including coagulation disorders or idiopathic pulmonary hemosiderosis. This table shows actually the causes of diffuse alveolar hemorrhage based on histological appearance. So you may find causes of capillaritis, you can find hemorrhages, you can find infections, inflammatory disorders, again drugs or toxins or other causes. This actually shows an algorithm for diagnosis of interstitial pulmonary hemocydrosis. So this algorithm starts with the presence of clinical manifestations of idiopathic pulmonary hemocydrosis. If you find that, like diffuse alveolar hemorrhage associated with iron deficiency anemia and abnormal chest radiograph, so you do a high resolution CT. You start with a high resolution CT, and you make investigations to exclude the other differential diagnoses. And if everything is negative, you do flexible bronchoscopy with a bronchoalveolar lavage, and you do a hematoxin eosin and Prussian blue stain and see if it is positive, if you have hemosiderin-laden macrophages or not. If you find, then this supports the idiopathic pulmonary hemocydrosis. If it's negative, then it's not idiopathic pulmonary hemocydrosis. And if it occurs that you take a transbronchial lung biopsy and also do a hematoxin eosin and see if there is capillaritis, then this is not an idiopathic pulmonary hemocydrosis. If there is no capillaritis, then you stain for immunoglobulins if it is positive. So this is again not idiopathic pulmonary hemocydrosis. If it's negative, then you do a Prussian blue stain and see if it's positive, then this is idiopathic pulmonary hemocydrosis. So what happened to our patient? Following the bronchoalveolar lavage, the patient had a complete evaluation looking for the etiology of alveolar hemorrhage. Echocardiogram was done and was normal. Coagulation studies were normal. Anti-neutrophil cytoplasmic antibody or ANCA was negative, and the anti-nuclear antibody titer was less than 80. Her urine analysis showed 2 plus blood and 5 to 10 RBCs. And interestingly, her antiglomerular basement membrane antibody was detected, and a renal biopsy was done and confirmed the diagnosis of Goodpasture syndrome. So now, this case shows the importance of proper history taking, proper follow-up of patient, the planning of a constructive the constructive way of a constructive way of planning of investigations to reach a final diagnosis. Although rare occurrence, iron deficiency can be caused by blood loss due to diffuse alveolar hemorrhage. The classic triad of diffuse alveolar hemorrhage is hemoptysis, iron deficiency anemia, diffuse pulmonary infiltrates. However, often the presentation is non-specific in young children. Identification of pulmonary hemorrhage requires a workup to identify the underlying cause of diffuse alveolar hemorrhage, and idiopathic pulmonary hemocydrosis is a diagnosis of exclusion. So this is my take-home message, that you have to know how to suspect a case of idiopathic pulmonary hemocydrosis or diffuse alveolar hemorrhage. In cases of diffuse alveolar hemorrhage, you have to search for a cause, and to diagnose idiopathic pulmonary hemocydrosis, this is a diagnosis of exclusion. And finally, I would thank you very much. Thank you for your attention, and hope it would be very useful to you. Thank you very much.